have 48 participants joining us, and I'm very, very happy that we've been able to get this webinar together. As you know, that most of us working on the national level are contemplating whether third doses or boosters are needed for those elderly and those immune compromised. And I couldn't think of a more up-to-date topic than what we now have. And I'm extremely happy to have Jakob Cramer from the Coalition for Epidemic Preparedness Innovations with us, and Jerome Kim from the International Vaccine Institute. We are very much looking forward to your talks. We have allocated 1 hour to each of you, and then we have the chat function where people can write their questions, and we can take questions from there in the chat. And if in the audience there are people who then want to share more than just in the chat, then I'll be happy to also provide you with the floor to speak out your questions. So with those words, I welcome you, Jakob, to share your thoughts whether vaccine there is need for boosters in the view of the emerging of variants and waning immunity. So Jakob, please.
Thank you so much. It's my pleasure and honor to present here today. Let me share my screen quickly. You should be seeing my slides.
Very well indeed.
Perfect, great. Okay, yeah, I think also thank the organizers for inviting me here today. It's a difficult topic. It is obviously a burning topic, but it's also a difficult one, which I'd like to highlight directly with my first slide. You all know that the Director General from the WHO, Dr. Tedros, a few weeks ago asked the global community not to booster until the end of September. And very recently, he confirmed again that there's little change in the global situation with respect to vaccines since that first moratorium. So he again called for an extension of this moratorium until the end of this year, until at least 40% of the world's populations are vaccinated. So there is several aspects that I think have to be taken into account. One is a vaccine supply, a political, a public health aspect, and the other one is an immunologic aspect. Should we booster because it does make sense from an immunologic, and then related to that, vaccine efficacy or effectiveness perspective. And I've seen that someone already texted in the chat, being from Israel. I have obviously brought several data or some slides from Israel here today, because I think that's a context from which we can learn a whole lot. So why booster in general? And I've just highlighted a few aspects here. This is probably incomplete, but it's just to illustrate it's not just to boost antibody titers, kind of to raise them up again. That's not just what we want to see. We don't even know what we actually need for protection. Do we need antibody titers? Do we need cellular immune response mechanism in this disease? But obviously to boost an immune response means to increase the titers, something that we can measure, but also to have an antibody maturation over time and so on. We prime and then boost also in order to prolong the immune response. We do see that titers decrease over time, and to do so and to maintain them up for a longer period of time, we know from many other vaccines that we eventually need to give an additional dose or even additional doses in regular time at regular time points. But I also want to highlight that by boosting, we can broaden the immune response. And I think some of the data that we have seen already from Israel in particular, but also from other studies show that this actually is indeed the case. So you know that last year when these vaccine efficacy studies had been performed, there was a perfect match between the circulating strains and the vaccine-contained SARS-CoV-2 strains, which is no longer the case. The original strain has more or less disappeared, and we have variants now. But we do not have variant-adapted vaccines. But we have seen that by giving additional doses, it does broaden the immune response and increases cross-neutralization against those variants. Now, there is an increasing complexity moving forward. And I already mentioned the term boost is maybe even a difficult one. I come back to that on the next slide. But just to go through a few aspects that have to be kept in mind when we talk about boosting. First of all, what is the primary objective that we have from a public health view? Do we want to influence the course of the pandemic by eventually ending the pandemic maybe, or even, or at least limiting its transmission, for which we may need high antibody titers? They may be related with vaccine effectiveness against infection and transmission. Or is our primary health objective to prevent morbidity and mortality? For which, yes, I think antibodies will be important as well, but there is some evidence pointing at cellular immune response mechanisms which are important to prevent progression from infection towards severe disease, hospitalization, and death. And for now, for the primary objective and the 90% or even much higher against severe endpoints, vaccine efficacy is against the second objective. It is much more difficult to achieve high vaccine effectiveness against the first objectives, in particular in the context of new variants. But we have seen that additional doses can lift the vaccine effectiveness against this first objective. So I've already mentioned broadening the immune response against variants of concerns, but also a practical aspect. We have primed populations, many people, usually with 2 vaccines. The majority of vaccines are based on a 2-dose primary immunization schedule. The majority of individuals have received twice the same vaccine. But that may be difficult a few months later, 6 months, 12 months later, whenever that individual comes back for booster vaccination. Will the health center, the family physician, whatever, still have that same vaccine available? Or can we give another vaccine? Should we maybe give another vaccine in the context of heterologous boosting? And if yes, which vaccine should be used for booster doses? Vaccines with the highest immunogenicity, or those vaccines which elicit the highest neutralizing antibody titers? Or should we mix and match and use vaccines that are stronger in terms of cellular immune response mechanisms? Or should we simply use the vaccine most widely available, which may be different from the first point? And then should we boost all or selected populations at risk? For example, immunocompromised, older age groups, chronic diseases, only for specific vaccines that have shown rather weakly immunogenicity after priming? Or should we prioritize healthcare workers, which are not necessarily at risk for severe disease, but certainly at risk for infection and hence transmission to those in risk of severe disease? I think it is important to look at what we actually mean by booster vaccinations. So in reality, the immune system doesn't really care if we call it priming or boosting. It just simply takes a few vaccinations to mount a good immune response, to maintain a good immune response, and maybe even to broaden the immune response. So the terminology and whether or not we should be boosting is something, more from our perspective, trying to give this some background and some context. We usually use 2 doses for the majority of vaccines, are based on 2 doses for priming, giving somewhere between 3 weeks to 3 months apart, dose 1 and 2. There's a few single dose vaccines out there as well, as you all know. What we usually refer to as boosting then later on is a single dose, usually given months, certainly maybe years, maybe even once every 10 years after priming has occurred. But there is vaccines out there, the hepatitis B vaccine, for example, that is given, the first 2 doses are given 4 weeks apart, and the 3rd dose has to be given within 6 to 12 months after the first 2 doses. And that 3rd dose is still part of the primary immunization schedule. You can call it an additional dose for priming, for example. So the point I'd like to make, and really to differentiate a little bit, are we really talking about boosting, and will we have to continue boosting over time? Or are we not talking about an additional dose that is required to complete the primary immune response in selected populations, so that are immunocompromised, for example, that do need a third dose to mount a good primary immune response? Do we need a third dose for some vaccines that are weakly immunogenic post 2 doses given for priming? Or in the context of kind of limiting, maybe ending this pandemic in the entire populations, do we need an additional dose in the context of 2+1 in the entire population, which would obviously then challenge the rollout of vaccine for priming, and as addressed by Tedros in his moratorium statement. So it's not so easy, and I can say that in the discussion at the moment, obviously, the approaches or the decisions of, I think it's already 15 countries that have released recommendations for booster vaccinations, it's quite a debate whether or not this should be done in the entire population, should be done at all, or in targeted population, or from a terminology perspective, this should be referred to as additional dose. Now, why should we consider additional doses? Isn't the immune response after 2 doses good enough? And here I'm starting with data from Israel. What is shown here is stratified by age, 16 through 39, 40 through 59, and 60 plus. The vaccine effectiveness, this is real world data against PCR confirmed SARS-CoV-2 infections. Stratified, each bar here shows the rate, the incidence rate of SARS-CoV-2 infection, depending on how far along the priming had occurred. And you can see that the incidence increases. So if the priming was done in January, the incidence is much higher and is lower if the time from infection or from primary immunization is reduced. That is quite striking here for the older age groups, but it's also present for younger age groups. The white bars illustrate populations in these age groups that did not have a vaccination recommendation initially, but these are healthcare workers who, in that age groups, who were included in the vaccine recommendations. So this is not the general population; it's really just healthcare workers. So you can see that the longer you have, the more time has passed from your primary immunization, then the risk of getting a SARS-CoV-2 infection increases. That also holds true for severe disease. This is the same stratification, the same concept here, but just now shown for SARS-CoV-2, COVID-19 severe disease. And it's quite striking that the risk in younger age groups seems to be, or is much lower as compared to the older age groups. And again, you see this time frame. So I mentioned the 2 objectives: limit transmission, prevent severe disease. From both perspectives, there seems to be an increase in risk of infection and severe disease over time. Next question, can we boost our existing vaccines? And the answer is yes. Clear answer is yes. So there is data that are being published now. I'm showing you some of that. Someone needs to go on mute, I think. Thank you. So this is some data from Moderna, from the Madonna vaccine. And this is actually a half dose Moderna vaccine. On the left-hand side, you see the half-dose mRNA vaccine containing the prototype serotype, so the original SARS-CoV-2 variant. And on the right-hand side, this is a variant-adapted vaccine under clinical trials. It's not licensed, as you know, half-dose with the 351 variant. And what you can see is the baseline titers before they received this third dose, and then the titers post third dose, 15 days, so 14 days post third dose. And you can see a significant increase for both vaccines. And that holds true for all antibodies, neutralizing antibody titers. These are pseudovirus neutralizing antibodies, which I'm showing, against different variants. This is the original variant. This is the formerly called South African variant, and this is the P1 variant that has been observed primarily in Latin America. You can see an increase in titers for all three variants, a significant increase. Data from the Pfizer BioNTech vaccine show or point in a similar direction. Again, this is immunogenicity data, serum neutralizing titers, so 1 month post dose 2. This is data from clinical trials, which they had conducted and then offered a third dose 6 months later. So this is the titers they had seen a month post dose 2, and then a month post dose 3. You can see in the younger age groups a significant increase in the titers. Green is again the original variant, and in blue is the Delta variant now. And this also holds true in older age groups, which are at risk for severe disease. So there is a huge booster effect, and it seems to be good immune response also against the Delta variant. I could show numerous additional data. This also holds true for the inactivated whole variant vaccines. They're also boosterable, and others have shown similar data as well. Now, that's great. So they are boostable in terms of neutralizing antibody titers, but how far does this translate into a clinical benefit? And again, data from Israel published very recently show that there is an increase in vaccine protection. There is a lot of discussion around these publications and the methods. This is again real world data, which obviously are not as planned and detailed as if you had a prospective, design, controlled, whatever, clinical trial or epi study. Nevertheless, they are providing us with very relevant information. So Israel, as you all know, had rolled out vaccines quite rapidly, primarily the Pfizer-BioNTech vaccine. And then on July 30th, Israel approved a booster vaccination with the Pfizer-BioNTech vaccine in 60+ adults. And what had been published here in this New England Journal paper is real-world data that had been observed from July 30th through August 31st. So really to assess the incidence, and it's quite, you see, over 1 million people, the incidence day by day after the first booster dose. And you can see the two groups, non-booster groups and booster groups, and again, the two primary public health objectives: to prevent infection and to prevent severe disease. You can see that the booster groups have a significantly decreased risk to get infected or to get severe disease in this older age population. This holds true across different age groups. This is data that had been shown at the FDA WPAC meeting a few days ago, where it had been discussed whether or not the US would like to booster with the Pfizer-BioNTech vaccine. And what I'm showing here is the fold reduction in rate compared to not boosting, so just 2 doses. And this dotted line here is 1, so everything that is above indicates a fold reduction in the risk of infection. And you can see that over time, it takes some time, and it was started on July 30th, but there is a clear trend towards an increase in protective effectiveness across age groups. So, and this is obviously data from the general population, not just from risk groups. So there seems to be a benefit. There is a few challenges, however. I already mentioned a heterologous priming or heterologous boosting regimen. This has been discussed both for heterologous primary immunization, but maybe even more relevant for heterologous boosting. The aim to go for heterologous boosting is to potentially improve the immune response in terms of breadth of immune response, peak antibody response duration. There is, the vaccines are different. Some activate different angles and branches from the immune responses compared to other vaccines. But the first question that public health agencies had, is this actually doable from a practical and operational approach? Are these vaccines interchangeable? Are they tolerable, or is it increasing the risk of side effects if I combine different vaccines? So the first question that was raised is, can we do this? And then the second question, should we do this by improving the immune response? There is some other ideas behind mix and match strategies. So potentially adjuvant antigen saving strategies, anti-vector immunity has always been mentioned. So if I give a third time, the same viral vector vaccine, for example, will I see an anti-vector immunity impairing the immune response? Or could I even improve the immune response if I give a different dose for booster as compared to priming? You know that some of the vaccines show a higher reactogenicity post-second dose given for priming. So it's not clear if a third dose would even increase potential local reactogenicity or even some of the described side effects. So there is studies that will come up shortly showing data on the immune response post-heterologous boosting. But what I'd like to show here with this slide is some data from heterologous primary immunizations from the University of Oxford. And just look at the upper left-hand figure and the lower right-hand figure. What the UK tested, or the University of Oxford tested, is two vaccines, the ChAdOx AstraZeneca vaccine and the Pfizer-BioNTech vaccine. The yellow line is 2 doses of the AstraZeneca vaccine. And I'm a little colorblind, but I think it's the top color here is 2 doses of the BioNTech vaccine. What you can see is that you will elicit much higher neutralizing immune responses measured as IgG binding assay antibodies here. You will get a much higher antibody immune response with a combination that includes at least 1 dose of the mRNA vaccine. The highest antibody titers shown or elicited with 2 doses of the mRNA vaccine. If you look at the lower right-hand figure, however, you can see that the best combination to trigger a cellular immune response is actually to start with AstraZeneca and then give a Pfizer-BioNTech mRNA vaccine as a second dose. So we don't know yet from an immune protective perspective whether or not we should give mRNA all the time, or if we should combine some of these vaccines. And that may also hold true for booster vaccinations. And there is further data that will come up shortly. Should we give reduced dose booster vaccinations or additional doses? Not just from a vaccine supply. I started with the comment from Dr. Tedros. So if we want to give a third dose, an additional dose, to selected populations, to everyone, is there a chance to reduce the dose to limit the impact on vaccine supply? Or again, should we do this because of reactogenicity and to reduce the reactogenicity? If we'd like to do that, we have some dose finding studies some of the vaccines have gone through dose finding studies in phase 1, but not all of them. So what is the dose that we could select? And some of them are formulated in a way that it is quite difficult to withdraw a fractional dose out of the respective vial. One would have to reformulate. The Pfizer, I spoke about the Pfizer vaccine quite a lot, is a 0.3 milliliter dose, full dose. So half of this would only be 0.15 milliliter, which is then already, causing operational challenges in terms of what syringe can I use, what needle, to make sure that I do inject 0.15 milliliters. And for the viral vector vaccines, it's even more difficult, as viral vector, the numbers of viral particles contained in the vaccine have quite a range of in the formulation. So just half the volume may still be within what is seen normally in the numbers of viral vectors contained in the vaccine dose. So if you really would like to go for a reduced dose for viral vector vaccines, it has to be a quarter or a fifth of the actual dose. We in CEPI are looking into this. We have started a platform trial approach, or we will publish this very shortly. And the idea is to look into this for booster doses, if that is a suitable way forward. We have defined some core elements for design features. So it has to be a single dose of a fractional versus a full dose given to selected primed populations. We also defined an interval between the single booster dose, and then the immunogenicity assessment and a few other aspects. What we'd like to look into is whether or not we can improve the immune response with a fractional versus full booster dose, and whether or not fractional dose is sufficient in terms of vaccine supply, but we'd also like to look whether or not this has a beneficial effect on reactogenicity. We would like to do this to generate some data that would support pragmatic decisions by NITEX rather than additional label claims. And already mentioned, the idea is to give a full dose followed by, full dose versus fractional dose. And we do define some core elements, as I said, but also some flexible elements. And the flexible elements will come from the proposed population that whoever is interested in conducting such a study will propose. It could be immunocompromised, solid organ transplant, HIV positive, elderly, immunosenescence. We are also interested in giving full versus fractional dose to those that are already primed. I'll come back to that in a minute. Chronic diseases. If there's vaccines that are rather weakly immunogenic or show rapidly decreasing antibody titers, it might it makes sense to give a third dose. So this is also something we'd like to look into, or incomplete or single dose primary immunization schedules. So all these populations can be selected and proposed to run a fractional versus full dose clinical trial, and we will support this trial then. 4-week interval. We would like to see in at least 3 months follow-up, but this can be prolonged for safety reasons and reactogenicity or safety in particular. This can be prolonged, and we would encourage additional time points for additional immunogenicity assessments later on at 6 months, for example. But these are really the core elements that we'd like to see to allow some comparison across these individual trials. That's why we call it a platform trial. Some defined core elements, but we would like to, if appropriate, perform some comparisons later on. So what I'd like to conclude with is another remark. This is showing the vaccine coverage for primary immunization, and in dark green it's vaccine coverage with a single dose or first dose, and then including the light green is 2 doses. And what you can see is that some countries, including Israel, this is not very up to date, this figure, I think it's a few weeks old, but the point I'd like to make is that a few countries have achieved very rapidly achieved high vaccine coverage. And there's some countries still today with vaccination coverage less than 5%. However, we in CEPI are doing or supporting clinical vaccine trials, and persons presenting to participate in these vaccine trials are tested as baseline for seropositivity. And we can see, we only have limited data, of course, not covering the entire globe, but what we can see is that the seropositivity has an inverse figure, as the one I'm showing here. We can see 50 and in one trial over 80% seropositivity in unvaccinated populations, while in Belgium, we see, for example, a 13% seropositivity rate in unvaccinated populations. So eventually, with or without vaccine, this world will proceed and will and the seropositivity rates will increase. So again, the question is, moving forward, about 2 doses, booster doses. I think this is fractional doses. This is something that we have to monitor, also from a safety reactogenicity perspective, as the world is increasingly seropositive. So I'd like to end with a few final remarks. We still need more vaccine and vaccines. There is a shift, as I said, from vaccinating immune naives to vaccinating prime populations. There is more SARS-CoV-2 variants, and there's no decision yet to adopt vaccines, but additional doses may be advantageous in terms of vaccine effectiveness against variants. And are there dose-sparing options? This is something we'd like to look into, not to challenge vaccine supply further, but maybe also to improve potentially the reactogenicity profile. With this, I'd like to conclude, and I'm happy to take questions. Thank you.
Thanks a lot, Jakob, for an excellent overview of a very difficult topic, which we're all struggling with. There are several questions in the chat box, and I would like to first invite the question from Marie Rosette Nahimana, who is asking on is the booster dose needed for all the COVID vaccines available? What is your thinking here? And she says, except for Moderna and Pfizer vaccine, is there evidence for need for boosters remaining available for the other vaccines such as AstraZeneca and Johnson & Johnson?
Yeah, based on what I've shown, it's not an easy question if a booster dose is needed. It depends on what should be achieved. I would say for some of the vaccines, we have been approached to look into the immune response post-booster. So there seems to be a tendency, for example, for ovarian inactivated vaccines, to include a 3rd dose. The way I see the mRNA vaccines, and we don't know, we have started vaccinating with mRNA vaccines, what is it, 9 months ago, for the first time in human history. We don't know a whole lot about mRNA vaccines and what type of immune response they elicit, what the duration of the immune response is in the context of COVID-19 vaccines. So we only learn as time passes by. It's difficult to answer this question finally yet, but I would say that at least for some populations, and not just the Israeli data point in that direction, many other investigations support that as well, that at least in some populations, a 3rd dose of mRNA vaccines is also a good idea, I would say. But whether or not, the question, whether or not we should boost for all vaccines is a difficult one, and I would not say that there is a general recommendation to boost everyone, as I completely concur with Dr. Tedros' perspective in that, if we need to balance a 3rd dose and with all those populations that haven't even been vaccinated with the 1st dose, then I think as long as vaccine supply is constrained, this is something that we need to be very careful about, and obviously have a focus on getting primary immunizations out to those in need. We haven't seen them yet.
There actually is a follow-up question, Jakob, on what would your recommendation be on the booster dose to countries which are still struggling to get enough vaccines to cover their population with the 1st and the 2nd dose. So what do you weigh in this respect?
Yeah, there is. I think I would. That's a difficult question. At first, you would say, well, focus on primary immunization and don't bother about a 3rd dose. Just use the vaccine and prime. You could even go further and say, use your 1st dose and get as many people, get a 1st dose into as many people as possible, and even delay the 2nd dose given for priming, not to speak about a 3rd dose given for booster. This is in the end a question for mathematical modeling, and I haven't seen those data yet. If you want to, again, it's really difficult to answer this question, and prioritizing effect on transmission infection over effects on severe disease. A third dose, or at least a focus on a second dose, is obviously important for those at risk for severe disease. Whereas a single or second, third dose is important for younger age groups to have an effect on infection and transmission. So it really depends on what your primary public health need is. Let's say if you are a very old population, you may want to focus on second and third doses. If you're a very young population, that has a lot of, where there's a lot, you may want to focus on a first dose and delay a second dose even, and focus on that. So you can maybe have a different recommendation depending on what population you look at. So you see that it's not that easy for me to answer this question. I think in the end, mathematical modeling is needed to do this, but in general, I think I would focus on primary immunization and then look into third doses, if you see my point.
Yeah, I think that's a fair answer, and really, I mean, if you there are modelers who are looking into whether you give a booster dose and what does that mean in terms of how much infection you can prevent versus how much disease you can prevent, and then if you do the calculus on how much your vaccine preventable disease incidence can be reduced by the first and second dose versus the third dose, I mean, those calculus actually end up with quite immense numbers on how much you need to numbers needed to vaccinate in order to prevent one serious case, then it really is on the side of the first and second dose, and have got those completed well before you actually move on to the third dose. So it really boils down to on what is your strategic aim of your program. But I mean, what you just showed us on the seropositivity of many of the countries, then Catherine Weil-Olivier is asking us on, could you discuss please a one-dose priming for healthy persons any age with a biological proof of COVID disease, plus a booster if recommended?
So
hi, Catherine.
So the question is if whether in young populations a single dose might be sufficient. Did I understand correctly?
Well, I mean,
in any age population, not only the young people, but adults, healthy adults, having a proof of COVID, not serology, but a TROD or a PCR, then why do you need 2 doses priming? And especially in adolescents, where we are worried about safety. And in the Western Europe, we are very prone to safety. So we propose a 1-dose vaccination priming.
It's, again, I knew it was a difficult topic here today. And then there's another good question, and difficult question. And you can see that it is a difficult question by the heterogeneity of recommendations we have, even in the European Union. Some countries still recommend a single dose if you have a proven natural infection. Others recommend a 2-dose immunization. It is even complicated by the fact that, we are opening up in Europe now, but you need to have you need to demonstrate full vaccination. And full vaccination for many vaccinations is 2 vaccines. So that's why some of the countries have, decided to go for 2 vaccines, irrespective of previous infection. I do think even, when I showed the numbers that even 10–14% of the populations, and these numbers are like 2 months old, so it's probably higher now. But even high-income countries, there's 10–14% seropositive, and all these have been vaccinated as well. So, we did not vaccinate and test each and every one for previous natural infection. I think there's a lot of people that have been vaccinated, given 2 doses, that didn't even know that they had been infected before. And I don't think that we are in a position to say that this has increased the reactogenicity or safety risks. From an immunological point of view, I concur with what you say. If you have been naturally infected, most likely a single dose is enough. Whether or not sometime later you should then get an additional dose, or booster dose, or whatever you want to call it, is still something that we need to find out. And then even natural infections, some have been very mild, very, just in the upper respiratory tract, not eliciting a profound immune response. While others who have gone through more systemic infection have a more profound. So even natural infection is not the same as natural infection, and it gets difficult. I tend to maybe make things more difficult than they are in the end, but I think your point is well taken, that natural infection, I would say a single dose is good enough, but whether or not, sometime later, 6-12 months later, they would also benefit from an additional dose, in particular in the context of variants of concern, still needs to be shown.
Okay, let's take, Jerome has got his hand up, and Jerome, you want to comment on this post-infection one dose?
Yeah, so I think I was going to cover this partially in my talk as well. That was great talk, yeah, Jakob. That was perfect. And but so I think we in our minds have to say, okay, what do we know and what do we need to know? And then finally, often we have to make decisions before we have a scientific answer. I mean, we have the data from neutralizing antibody, boosting, 2 doses with a third dose, or boosting natural infection with 1 dose or 2 doses. What we don't know is what that really corresponds to from an effectiveness perspective, which is what matters for most countries at this point. But that can't keep us from making a decision. The other thing that we don't know has to do with durability. And those studies really need to be done, because at some point we want to inform our best guess by data. So I think that Jakob's point is exactly right. We start these large trials now as quickly as we can, looking at different combinations. And and I'll actually show some data from a country that was using Sinovac. We don't know. And a lot of countries are using lots of different vaccines, and we have to separate what we know from what we want to know, and then design the experiments around them. But at the same time, we need to make decisions around I think that Jakob's answer was the only one that we could give, which is we need to make sure that the highest risk populations all over the world are vaccinated to protect them against infection. And, we're concerned about transmission and herd protection and all these other things. Different parts of the world are at different stages, but right now protecting people from what we know will kill them is really a critical concept. And it's one that, getting to that level where the people at greatest risk are protected is key.
Thanks, Jerome. And there is a question from Ron Duggan in the chat box, commenting from Israel. And he said that Israel was concerned about partial vaccination, that is 1 dose and delay the 2nd dose, and its potential on promotion the variants. And what do we now know on the partial protection and what it does to the variant evolution?
Honestly, I don't know. I know about this discussion. There was a lot of, there was these 2 positions. One, and you remember the initial discussion in the UK with the AstraZeneca licensure and recommendation, in that they actually recommended a 3-month interval for the 2 doses given for primary immunization. With the initial thought to increase vaccine coverage as quickly as possible, and the hope to at least prevent severe disease with a single dose, and then to complete this later on. This discussion has then kind of turned into the other direction when the variants came up. Should we not complete 2 doses as quickly as possible to shift from a focus on severe disease to a focus on preventing infection and potentially generating new variants? I'm not a virologist, I have to say. I'm not sure how far we are in a position to say that incomplete vaccinations, and I'm not saying that this is incomplete immunization. I mean, some of the vaccines are based on 2 doses, viral vectors, while others are not. And I think there's room to argue, is one really a 2-dose regimen while the other one is a single-dose regimen? So it's too early, I think to say that at least I don't know if single dose or incomplete 2-dose prime immunization has increased the risk to generate new variants. I would say that's not the case. I don't think there is data supporting that. And I don't think this should be our primary focus. But again, to talk about booster doses now in the general population in high-income countries, and at the same time to talk about single dose and delaying the second dose for prime immunization in low and middle-income countries is a difficult discussion. And therefore, I'm completely with Dr. Tedros. The focus should be on rolling out prime immunization vaccines globally before we move on. I do think, if I may make that comment as well, I do think we will see a relaxed vaccine. I shouldn't say I think, I hope. I hope that we will see a relaxed vaccination supply situation next year. And that maybe some of these discussions will then, be less complicated. But again, it would be nice to see high vaccination coverage now and not just next year.
Sure. Jerome, you have a contribution to this with your virological background, please.
Well, I'm not sure if it's going to be much of a contribution, but I think it's, we do have data from the UK that really for the Delta variant, you need 2 doses. And so in settings where there are variants that require 2 doses, giving a single dose is not protecting, so it may not generate new variants by itself, but the fact that the outbreaks can continue in the interval between doses and transmission could continue has the potential to generate new variants. Will any of them actually be able to overcome the vaccine-induced immune responses? I don't know. I mean, at equal risk are countries that haven't started vaccination, who have large numbers of people whose initial infections were during the first wave and the second wave. We know that reinfections occur. Overcoming naturally induced immune responses is an equal problem because those variants could easily escape the vaccine-induced immune responses. So again, there are risks on both sides from under-vaccinating because of the continued spread of Delta, but from also countries that don't have vaccine because we're not able, and actually many of the countries are not either diagnosing infection or sequencing breakthroughs. These infections in people who've already, we've seen that in some of the clinical trials in the West, in high-income countries, that there are clearly reinfections among people who've been primarily infected and then people who've been vaccinated. So there's a lot that we don't know and a lot that science, I think, should contribute to helping to understand what the appropriate time is for the dosing additional vaccine.
You're right. That is so true. And Nicholas Payrod is asking whether regarding booster dose, there's any signal with some COVID vaccines of potential original antigenic sin, something similar to what is seen with influenza vaccines. Is anybody looking into that? Do we have any signals?
That is something that we keep an eye on. This is also important when it comes to variant vaccines, potentially in the future. So far, we are good, at least against severe disease. But I'm not aware that any of the trials really show clear evidence of original antigenic sin so far.
Jerome, are you aware?
No, I think people have been, again, on the lookout for it, but the significant increase in cross-neutralizing titers that you get when you boost an infected person might suggest that natural immune responses and hopefully vaccine-induced immune responses are capable of, and what you see when in terms of the breadth of response when you vaccinate someone, when you heterologously boost somebody, would suggest that the current, at least, set of vaccines protect against the current variants. Now, who knows if new or ADA, one of the other, the new variants is going to be create a different immunotype that is going to be, a real problem for this original antigenic sin question, but certainly not in the way we think that we see it with HIV, which actually has a number of dummy epitopes and immunodominant epitopes that have no consequence for protection. So anyway, that's just, it's a slightly different virus, and it mutates rather slowly compared to even influenza, but certainly HIV. But again, I don't think we know that yet.
Mm-hmm. Then there is also a question on those who are severely immune compromised. What do we know about passive immunization? On would that rather be the way to go than giving third and fourth doses?
That is something that is being explored. Passive immunization is comes also with challenges, of course. You need respective antibodies to be widely available and to be, shipped. And from a global perspective, I think it's challenging, I guess. But this is an option. These are under development, and it's also not clear for how long they are going to provide a passive protection. There is data from heterologous priming studies in immunocompromised populations indicating that indeed it is difficult to elicit a good immune response with 2 doses. Seems to be some data indicating an advantage of heterologous immunization regimen, but I think even that is still too early to decide. We are also supporting a study in immunocompromised, in solid organ transplant patients. Those data still have to come. Yeah.
Right, okay. There are comments from Fiona Russell on the Cuban study where there is trialing on 1 dose after infection, and then she also is commenting on the urgency of the inactivated vaccines and the booster dose. But Jerome, you're touching upon that in your presentation, so maybe we'll come back to Fiona's question and also Sarah Waddle's question on what we know about the stages of the version of protein subunit vaccines and whether we should wait for those. So shall we at this point thank for all the excellent questions and excellent comments, and then move on, Jerome, with your talk, and then take the rest of the questions there.
Okay, thanks, Jacob. That was really a difficult act to follow, and I apologize. My camera, I have a new computer and my camera is not working. We have not been able to figure out what the problem is. So you'll hear my voice, but unfortunately, well, probably fortunately for me, you won't be able to see me as I do this. So thank you. And unfortunately, again, Jacob and I didn't have enough time to coordinate beforehand. Otherwise, you are probably going to see similar graphs, and I'll try to emphasize slightly different points. Actually, some of them have already been brought up in discussion. I think the discussion after Jacob's talk was really incredible and very informative. So these are my disclosures. I think everyone knows that there's been tremendous innovation induced by the COVID pandemic and necessary innovation, because we were really in a situation where we didn't have any vaccines. This was a novel virus, and within 11 months there were vaccines that were shown to be safe and efficacious, and there are a lot more in the pipeline. And as you can see here, I mean, 102 vaccines now, actually more than a year and a half into the pandemic, in clinical testing, and additional vaccines in preclinical testing, and how you position those new vaccines, these new concepts, and how they might contribute or not contribute to the final control over COVID-19, I think is a real question, and something that organizations like CEPI and the US NIH and the Horizons program and others are going to really need to think carefully about and design trials and experiments that will answer really critical questions around transmission and interruption of transmission, herd immunity, and relevant immune responses, including the question that we had on original sin, antigenic original sin, not the theological original sin. So these are some of the vaccines, and actually I've updated this now to include the Zydus Cadila vaccine. I mean, we've seen new platforms, we've seen a much more extensive use of novel antigens, including the one that's in the Bharat-Hole inactivated virus vaccine, the extensive use of AS03 with protein vaccines, the Novavax vaccine with its matrix, with its adjuvant as well. I mean, this has been a real time for innovation. I've still divided the vaccines up by their original ID50 neutralizing antibody titers, and you can see them broken into 3 groups: those with ID50s under 100 in gray, 100 to 500 in yellow, and greater than 1,000 in green. And this may get to one of the questions, I think, I can't remember who asked it, about where the next set of vaccines that aren't RNA are coming from. Well, Novavax is one of the protein vaccines. Of course, Sanofi has one that's also in phase 3 now. And of course, Clover just announced its very interesting safety and efficacy data. It also has a protein vaccine with a alum CpG adjuvant. So again, very interesting data that's coming forward on protein vaccines as well. And you can see those here. Wave 1 are the vaccines that we know about, that we've known about now for 7 or 8 months, with safety and efficacy data reported for most of them, with a question of when Novavax is finally going to get approved, and now we actually have data from CureVac, Zydus Cadila, Clover, soon I hope from Biological E, which is another protein vaccine using the Baylor College of Medicine RBD, receptor binding domain. So there's a lot of excitement still in wave what's called wave 1A, and then of course wave 2. There's been a lot of progress there as well, including progress on protein-based vaccines. So we have 13 vaccines. I've now thrown in the Zydus Cadila vaccine as well, showing short-term efficacy and safety. What's next? And I've always thought about optimization of dose schedule and boost as one of the most important questions. I've been using this slide for a while now. And we're going to focus on the booster question. But it does get, and as Jakob, and in an answer to one of the questions pointed out, there are things we don't understand about the dose, because when does a single vaccine given at month time 0 followed by a vaccine at month 3 or month 4, is that a prime and a boost, or is that a 2-dose regimen with a standard 4-month dosing interval? Correlates of protection, which actually could play a little bit into the questions around the boost and selection of boosts. Effectiveness in herd immunity, which is a larger question, I think, that is still looming, but again, can be related to some of the questions around booster doses. And then the other ones around mutations and surveillance, around safety, long-term safety follow-up, and opposition to vaccination are ones that aren't going to be covered. So this is a slide that I often use because I think it's really fascinating. So this was the original AstraZeneca study. And the highlight here, LD/SD, is the low dose, the roughly half dose that some people got, roughly 3,000 people got in the beginning, before they realized that it wasn't really a full dose and they were giving a smaller amount. Followed at least a month later, again, because initially this was supposed to be a 1-dose regimen. The protocol was modified to add a second full dose. But because the protocol had already started, some people got it at 1 month, some people at 2, 3, 4, and so forth. And so we had 2 natural experiments. We had a fractional dosing first, followed by full dose, and then an interval of between 1 month and 3 months for the second dose. So 2 interesting experiments and 2 very interesting results. Of course, the low dose standard dose had an efficacy of 90%. The 2 standard doses, this is the original AstraZeneca trial, had an efficacy around 60%. So again, suggesting that there's something about that prime followed by a higher or stronger boost that might be important in generating the kinds of immune responses that protect you against disease. The second part of the AstraZeneca trial, the second very interesting finding, is that efficacy increased as the interval between the prime and the boost increased. And again, we have data from other vaccines that increasing the length of the boost, particularly in HIV vaccines, if you space out the boost better or longer, you get much higher antibody titers or neutralizing antibody titers with the boost if you distance it from the prime. And that's exactly what we've seen with efficacy here for the AstraZeneca vaccine. Other vaccines that have done this, not really, except that Sinovac actually did an experiment comparing 2 weeks versus 4 weeks for its second dose. And 4 weeks actually had a higher level of neutralizing antibody, again, suggesting that spacing is important. And what would happen if we gave a third dose? And actually, you'll see some of the data. So Jakob covered this slide already. You know, the elderly are a population that has poorer immune responses, and you see that in the in this case in the Janssen data. You know, these are geometric mean neutralizing antibody titers in black for the greater than 65-year-olds and in blue for the 18 to 55-year-olds. And I think importantly, at the level of detection, by about 9 months, 8 to 9 months out from the initial single dose of Janssen vaccine, 68% of people had detectable titers if they were over 65, compared to 95% at a slightly different time point for people between the ages of 18 and 55. So again, you saw a much lower level of detectable neutralizing antibody in the elderly. And again, does that correspond to some aspect of protection? We think so. In fact, the data from one of the COVAX working groups suggests that in fact, yes, neutralizing antibody, binding antibody in phase 2 does seem to predict what happens in phase 3 from the efficacy, but Janssen have not published their correlates data yet. But interestingly, now, if at day 169 they give a second dose, you get a substantial increase in titer. And the booster dose is actually not at the same level as the original prime, but you see a 9-fold increase in neutralizing antibody in the over 65s, a smaller boost, but a significant boost in the 18 to 55-year-old age group. So again, we know that this corresponds to increases in neutralizing antibody. We think that that's important. At least it was for the primary series. Could it be different for the boost? Probably not, but we still haven't shown that for the Janssen vaccine. This is the data from Sinovac, and it shows 2 doses of Sinovac, and then followed then with a placebo in the upper left-hand corner, with a second dose of Sinovac, which increases the level of neutralizing antibody ID50 by about 1 log. Then if you use AstraZeneca, which increases it between a log and a half, and Pfizer, which increases it by about 2 logs. Now, if you look at the number of dots, you can tell this is not a large series, but it does suggest that both homologous and heterologous boosting of a Sinovac, so a whole inactivated vaccine, with an adenoviral vector or an mRNA vector result in significant increases in neutralizing antibody titers. Now, whether those again correspond to, so we have test tube data, we don't have real world data on effectiveness, but we think that the neutralizing antibody titers may be related somehow to protection against disease. And so this could be important, but again, gets to the idea that homologous or heterologous boosts with the whole inactivated virus vaccine as a prime are able to significantly increase antibody titers. So I think this one is this study, which is the one from the Oxford group, is really interesting because it gets to something that we found in HIV as well. What we found in HIV is that if you're giving mixed primes and boosts, you probably want to give the weaker vaccine first and the stronger vaccine second. And that's exactly what they saw here with the COVID vaccines. If you use the AstraZeneca vaccine alone, so 2 doses of AstraZeneca, you get a neutralizing antibody titer, a PNT50 of 1,392. If you give AstraZeneca followed by BioNTech or Pfizer, you get 12,906. If you give 2 doses of BioNTech Pfizer vaccine, you get 14,000, which is not that different from 12,906. If you use the strong vaccine first, you get a titer that is half that. So you get a titer of 7,133. Again, arguing that if you're going to give a heterologous prime boost, maybe you give the weaker, the vaccine that induces the lower target immune response first, followed by the second one. And this is somewhat consistent with much of what we've seen in HIV, where we've done a lot of heterologous prime boost studies. So does the order of vaccines as prime and boost matter? So until recently, I was saying that, well, it's all well and good that all this booster stuff works in a test tube, that we can detect higher levels of neutralizing antibody. And does that really mean anything in the real world? So of course, and like actually Jacob covered this, so I won't really, other than to say, yes, we're starting to see real world data that the the use of boosters is associated with improvement in outcomes, actual outcomes. And this of course is the data from Israel, which is very nice. And you know, particularly in the elderly, this effect was something that that changed minds about the need for boosters in certain higher risk populations. Immune correlates. So again, you know, we've talked about this a lot, and actually we have data now. What's shown on the right is the one from Moderna. It's the first author is Gilbert, and the second one is the one from the Oxford group. Again, suggesting that there are going to be titers that are associated with significant, or that are associated with statistically significant p-values associated with reduction in disease. And what you see in the upper left-hand panel is something from the COVAX SWAT team. Again, with all the different data from phase 2 studies, you take the whatever the reported binding antibody titer or neutralizing antibody titer is, you control for the convalescent human sera, which actually in a way controls for the assay that's done, and all the assays were different. And you get a ratio, and that ratio actually corresponds to the efficacy that was seen in the various clinical trials done for a number of different vaccines, including the Mrna vaccine. So a very useful number. We think neutralizing antibody or binding antibody might be important, but how does that correlate? And what does that tell us about long-term protection in booster mode? And again, this gets to a question that may have been answered partially by the data from Israel earlier. I'm going to focus on the last part of the talk on efficacy, effectiveness, and herd immunity, because it's something that we've been thinking a lot about in countries, and for instance, in Korea, where the rate of vaccination single dose is up in the 74% range now, but where we're having, you know, up to 3,000 infections a day, which is an all-time peak, but the hospitals aren't full. The ICUs are the same level that they were during the summer outbreak, which was at less than half the level per day of total number of infections. What's shown here are the different diseases. Actually, this is taken from Plotkin, if you're interested in finding the table. The R-naughts, the herd immunity thresholds, vaccine efficacy, and I mean, look at measles. Of course, we've seen outbreaks of measles in countries. Korea, for instance, is roughly 95% vaccinated against measles. There were small outbreaks as measles was imported from the Philippines, but there was never a large outbreak. There were individual cases, and the country went about and did additional vaccinations. A way to think about this is that efficacy, what we measure in phase 3 trials, is direct measurement without bias, because that's what the trials are designed to do, to protect individuals against infection. Effectiveness looks at direct protection of populations with regard to real-world outcomes, so severe infection, hospitalization, and death. But there are people who are unvaccinated who are going to get infected, and that's often the basis for the comparison of the effectiveness of the vaccine in this population. Where we're going, hopefully, is to understand impact, which not only measures the direct result of protection, that is the group circled in green, but also the protection of people who are not vaccinated. Those are the people in the dotted green line, and that's the indirect protection. Now, how does a booster impact that? Do boosters really decrease transmission? And we really don't know that. We don't actually have much information about transmission in households. For instance, there's some AstraZeneca data around that, and it's very interesting. But we really need to know if any of these new vaccines, if we use a protein boost to an RNA vaccine or to an AstraZeneca vaccine, will that significantly impact viral load or prevent acquisition of infection? So preventing infection itself or lowering the viral load post-infection may significantly impact transmission. Let's not miss this opportunity as we're testing vaccines as boosters to really carefully evaluate the impact of these booster doses on interruption of transmission, because the interruption of transmission will help us to answer or maybe get a better opportunity to show a benefit in impact. Because right now, you know, does the Delta virus have a similar infectivity do people who are infected with Delta have the same nasopharyngeal viral loads as people who are unvaccinated? Is the level the same? And therefore, can they transmit as well? That's what some data would suggest. So that might suggest, again, that there's actually modeling around this, that the use of vaccines in the context of Delta is could actually prolong the outbreak. And it's the combined use of vaccines and other methods, so non-pharmacological interventions like masks and distancing, avoiding crowds, in addition to vaccination, so a systematic approach to prevention that may be important. And maybe it's time that we start thinking about these things. But importantly, as we look at the boosts, let's look at some of the things that are unanswered questions in the future. So let's see. So this is the situation. We have outbreaks, the outbreaks generate variants, and then the variants cause new outbreaks. And one of these days, we're going to see the variants cause an outbreak in people who are already infected. And we know that. And the big question is, will vaccination be able to interrupt this cycle of outbreaks and variants? And that's going to be a really critical question for boosts, because as more and more of the world, and I think we're now above 60% of the world has received at least a single dose. We still have a lot of work to do in order to get the people in the low-income countries, where only 3% of people have received the first dose, vaccinated. We need to protect the people at greatest risk. And we need to understand how we're going to break this cycle of transmission and outbreaks and variants. So is there a booster in your future? So we know that homologous boosts increase neutralizing antibody levels, and we have some data now from Israel that there actually is benefit. Heterologous prime boosts, do you give does it matter which vaccine we give first? And that's increasingly a question in countries that have 5, 6, 7 different vaccines being used in circulation. And it might be difficult sometimes to tell what vaccine a person got first, as we're seeing in some of the countries that we're talking to about some of these additional studies. Does increasing neutralizing antibody increase protection after boosting by decreasing infection or severity of disease? And again, unknowns, although there's some data now that would suggest that we are seeing an impact on severity. Does decreasing effectiveness imply a waning of the immune response or a changing of the variants? And again, this was something that has come up repeatedly. Is the quote, waning immunity and the increased infection among vaccine recipients a consequence of the fact that there's Delta now, and Delta is slightly more resistant to vaccine-induced neutralizing antibody, or is it because neutralizing antibody titers have gone from 400 to 250, and that there are a significant number of people who are now below the level of detection? So again, really important questions to answer that are going to require the same kind of systematic analysis that was best done in well-designed clinical trials. Could random mixing and matching hurt? And I think this gets to part of the original antigenic sin question, but also, could you actually be impairing responses by forcing the immune response to, to deal with a slightly different sequence, or, and we don't know that right now. But it would be important and again, the reason to do these carefully designed trials is to really understand what happens when we mix and match. So finally, this is a plea more than anything. As we look at the boosters, let's subject them to systematic and not empirical testing. And I know that the temptation is out there to just, to give whatever we have. But if we're going to do that, let's at least collect some data on it so that we have, and I would say that study with the Sinovac Prime is a good example of understanding what it is we're doing when we give heterologous boosts or homologous boosts in the case of Sinovac. And again, the question, I think this came up in the chat, should we vaccinate everyone before we give boosters to those who are not elderly or immune compromised or present any particular risk of acquisition or transmission? And again, that is the question that was asked actually several times in the chat. So thank you. Hanna, we can't hear you. Hanna, you're on mute.
Okay, the host would not unmute me, so now I'm here. Thanks a lot, Jerome. Excellent talk, and probably raises more questions than gives answers. And I'm just reading through the chat here. where Pierre Van Damme is telling us that hearing all this, the question remains, what is the ideal schedule? We couldn't take the time needed to study the ideal vaccine schedule, as we did not help as we did for hepatitis B or HPV, but it might be that we all need a 0, 1 month and 6 month schedule to well invest in immune memory and protection and blocking transmission, or at least in some age groups, it is time to better study schedule and compare. And then my question to you, Jerome, is that you also said that we should not do this at random, but we should do it systematically. But how do we do this systematically with the epidemic ongoing and there actually being a lot of kind of a money interest in all of this? How do you see that we will be able to do a rather systematic approach?
So one way, and I would guess that perhaps the U.S. with its having taken the HIV vaccine trials network and turned it into a COVID vaccine trials network, being able to conduct these larger scale clinical trials using networks might be something that that different groups in Europe, in Africa, Latin America, and Asia could get together to make a large clinical trial network that would execute a trial, for instance, that CEPI has, or that WHO has put together, that would, again, hopefully very rapidly, and again, we would have to use not necessarily the pharmaceutical model of, get all the sites together and the first that start enroll, but the questions become increasingly difficult to answer as there's more and more heterogeneity in within country use of vaccines. So we were going to do some studies in Mozambique, and all of a sudden 9 million doses of Janssen vaccine appeared as a gift from the US government, and 1 million doses of Sinopharm appeared as a gift from the Chinese government. And you're scrambling to do something that was a well-designed trial and trying to figure out what you can do now that the system is changing. So, putting together the network, the funding, and a clear set of protocols that can be rapidly put into place, I think would be really important. We can't do the same trials everywhere, and so if countries or regions, I guess, like Europe, are going to make a decision or a recommendation, then smaller studies that are appropriately sized to have power to answer a question are still a good answer. I mean, they're better than not collecting data at all. But it's the Sinovac trial data that were reported are probably not appropriately sized, but they raise some really interesting and valid observations.
Indeed. Then there is a question from Sarah Waddle after hearing these two talks on what is the status of the data on RNA Delta variant vaccines, stages for variant versions of protein subunit vaccines, and in countries with high vaccine uptake on primary vaccination in a few cases, would you recommend to wait for these new vaccines for boosting?
So I think actually Jacob's probably better positioned to answer that, since CEPI is actually moving a number of these forward. We are working on both multivalent approaches and pan COVID-19 approaches that are in the clinic. So, but it's going to be well into next year. And Jakob, you have probably a lot more insight into this.
Not sure, but what I can say is that CEPI is supporting both the Novavax vaccine, but also the Chinese Clover vaccine. And you've probably seen that the Clover vaccine has read out phase 3 vaccine efficacy data very recently. And I think what is really interesting about the phase 3 data, the Clover phase 3 data in particular, is that in their trial, they have seen 50% seropositivity rate, which again, as I said in my presentation, ranged from, I think, 13% in Belgium and greater than 50-60% in some other countries. So Clover has a lot of data on vaccinating seropositive subjects, and they still analyze these data. Obviously, they have data post on the immunogenicity post first dose. This is a 2-dose regimen as well for post first dose in seropositives, and they do see good immune response. They also looked into vaccine efficacy in the seropositive subjects, but for 2 doses, and they also see some interesting results there, and that they actually do see vaccine efficacy, even if you vaccinate, increased vaccine efficacy in vaccinated seropositives as compared to unvaccinated seropositives. Furthermore, the CLOVER trial has included a series of variants, Delta variant primarily, but also the Mu variant in Latin America, not a single original variant. By the way, all the data can be found, that actually published the entire results slide deck on their homepage, CLOVER company. So they've seen a lot of variants there, and I'm very curious to see data stratified by seropositivity. I'm in particular interested in seeing further analyses out of the seropositive trial subjects, but also stratified by variants. So I don't really have a much better response than Jerome with regards to booster and adjuvanted protein vaccines, subunit vaccines. Other than what I just said, this will still come up. They seem to be very immunogenic. I would assume that they're a good booster option as well. There is studies ongoing in Brazil, for example, with a CLOVER booster post other vaccines, I think post AstraZeneca and post Sinovac vaccine in Brazil. These data will come out shortly, but I haven't seen anything yet.
Well, that actually brings me to the other question that Hans van Vliet was asking on is there any systematic information about the boosting effect of mild infections after a complete primary series, or is somebody looking at that in a cohort manner?
So another good question. And these are really, I mean, you've probably also seen the recent publication showing a broad protection in those that had been infected years ago with SARS-1, who had then, received vaccination against SARS-2. This broadens the immune response significantly. I would assume that this is a good booster effect, and that kind of brings me back to what I said initially. Even if the antibody titers decrease rapidly, that does not mean that you're no longer protected. We have seen for all of the vaccines, including the whole variant inactivated vaccines, that they do have a fairly good booster immune response. So they elicit a good memory immune response. And natural infection could elicit another increase of the immune titers, maybe not to prevent another infection potentially, but I would say it's still going to protect against the progression towards severe disease in time. But I haven't seen any specific cohort data. These are quite difficult to obtain. And I haven't, because you have to look for natural infections. And then if you would like to look at the immune response, then perform additional blood draws and analysis. And it is difficult to obtain this from real world data. And prospectively planned studies would have to be fairly large, to get enough cases. So these questions are very relevant. I'm not sure how far and how quick we will see really good data on these to answer these types of questions.
Yeah, I agree with you. And when Jerome was talking about the indirect protection and mentioned the household studies, I mean, having done a household study here in Finland, where things are pretty orderly, it's a huge effort on trying to understand the chains of transmission and include all those potential biases that goes into that on trying to understand people's contacts and then doing the swabbing and doing the virological sequence analysis. So those are would be hugely important, but hugely difficult to do. Jerome, are you working on household or transmission studies in your domains? And do you see that what is the minimum level of information that we need from those in order to guide us regarding the indirect protection?
Yes. So Hanna, the CEPI is supporting CLOVER with IVI to do a household transmission study in the Philippines. And actually, we're expecting data out in the next few months. So I don't have the answer to that. It is complicated, and there are the questions aren't actually. We're not sure. I mean, we're hoping that the design is sufficient to answer the question. But as you pointed out, it's the execution of these household transmission studies is difficult. I mean, in the AstraZeneca trial, I believe that they sent out swabs, extra swabs to people so that they could test family members. And this was in the UK, and there was an impact on household transmission. So again, this was pre-Delta variant, and we don't know that it will continue to work that way. I'm actually a bit relieved by the Clover data. I mean, the fact that almost all, I mean, the vaccine was tested in a variant-rich environment and still showed efficacy. And then, the question is, will it have an impact on household transmission, which I think is really an important one.
What's your thinking now that we are in the household transmission and transmission in general on should that really be the strategic aim of these national programs? I mean, so far we've been thinking that it's preventing the serious disease, and we've been concerned that the neutralizing antibodies, they wane so rapidly that the indirect protection would not be something that we would name as a strategic goal. But do you think that this game is changing with the booster doses?
So I don't know. I know that some of the there are some interesting new vaccines, maybe the protein vaccines or perhaps the booster doses of mRNA vaccines that will get antibody titers up higher, and maybe that will have an impact, or maybe the induction of new T cell responses by some of the, for instance, the adenoviral vectors. Will, in addition to what was generated with a whole inactivated virus or an RNA vaccine, again, will have additional effect. We really don't know. And, again, I think as the new vaccines are being brought online, I think that these are questions that we should look at. And I don't want to raise the human challenge issue, but this would be something that we could look at in a human challenge study, particularly now as some of the antiretrovirals are looking like they may be better, and we have actually clear guidelines on prevention of more severe disease, that maybe it's time to start looking at this question in people who would be challenged with different viruses. Like I think Imperial College has a model now set up. And, we can look and see what the impact is on nasopharyngeal viral loads. Or on, what's present in aerosolized particles from people who are challenged after being vaccinated or after being vaccinated and boosted or heterologous prime boosts. I mean, that might give us additional information that will help us think about the design of these, either household transmission or virtual cluster or these other types of epidemiological designs that people use to look at indirect protection.
So thanks, Jerome. Are you aware of people working towards human challenge right now? Are you in IVI or Jakob, are you supporting in CEPI human challenge studies?
Yeah, so this is being developed. To my knowledge, there is a first study that has been conducted in humans by the Imperial College in London. The data are not yet published. I don't know them, but we are currently, urgently waiting for those data. There is some discussions, and we are in discussions with the One Day Sooner group, but also with the Wellcome Trust. I think this is still an interesting and very relevant concept, but one has to, be clear what the expectation is and what we can get out of a human challenge model. In human challenge models, we will use 18 through 25-year-old healthy young people. They will not show severe disease. So the data we will get out of a trial with 20 or 10 challenged subjects on severe disease protection is very limited, if anything. The model is much better if you would like to look into transmission and infection, of course. So for these types of studies, that might be a suitable way forward. but those studies are not yet underway. So a first really human challenge study has recently been done by the Imperial College, but I haven't seen any data yet.
Okay, thanks a lot for the reminder. Yes. Well, then Sarah Waddle is asking us about to what extent do you think data on cellular immunity can help guide decision for boosters, especially with regards to severe disease?
So, sorry, go ahead, Jakob.
No, go ahead. I was just going to say, would like to hear Jerome's, but I'm happy to respond as well after you.
Yeah, no, I think we're probably going to answer very similarly. You know, so I think cellular immunity is important, particularly as it relates to, for instance, the generation of long-term memory, particularly for B cells. And we don't actually know that much about the T follicular helper and the other populations that would be operative in a lymph node type environment. The other parts of cellular immunity, the CD8 and maybe even CD4 populations that are making interferon gamma and IL-2 and others are we talk about them. Actually, in the monkey data from, I think, Dan Baruch's group, it wasn't necessarily shown to be a correlate of protection in the monkey study. They used a DNA vaccine though. But I think that this is a very important and legitimate question. And you know, some of the vaccines that are in the next generation include vaccines that look particularly at T cell epitopes. You know, would a live attenuated vaccine generate those kinds of protective immune responses better? With the choice of adenoviral vectors, and I think Hanna, we talked about this on one of the groups you were with. You know, we already know that, for instance, Ad5, or this is from our experience with HIV, but other viruses as well, that if you put the insert into Ad5, you tend to generate more CE8 type responses. With Ad26, you get a much more balanced response. You know, the Oxford group and the choice of chimpanzee adenoviruses was informed by the differential effect of these adenoviruses on cell-based immune responses. So again, right now, I think the correlates point to antibody, but in part that's because it's much more difficult to standardize the assays for correlates around T cell based assays. I don't know, Jakob, if you have more. I mean, you're on the working group, so of course you do.
I don't think I have much more to add to to your response, Jerome. Maybe just from a vaccine development regulatory perspective, just the one comment that it is difficult to assess the cellular immune response and then also to base decisions on it. And the regulators are careful simply because cellular immune response is notoriously difficult to assess and then compare, depending on what you actually assess. But if it is based on cells, then the storage, the sampling is important, and then the reproducibility of respective assays is limited. There is validated CMI assays out there, I agree, but so far it has been an ongoing debate whether or not immune markers out of the cellular immune response could or should be used for licensure decisions. I completely agree with Jerome, of course, in that CMI is important. I'm quite sure that, as I said, there is this discussion whether or not a CMI actually plays a pivotal role in preventing the progression towards severe disease rather than infection in the upper respiratory tract. But that, I mean, again, we are still learning. There is some data, as Jerome summarized, indicating that the prolonged interval is beneficial for the antibody, the humoral immune response. We will see if maybe shorter intervals are actually better for the cellular immune response. So there is additional data, coming up, and information that we have to look at to come to a decision. For now, I don't think that anything measured out of the cellular immune response world will guide us, or only as a sole marker will guide us on decisions with regard to booster vaccination for the vaccines widely used at the moment.
Okay. Then there is a question also from Fiona Russell on asking on our studies being done to look at 2 homologous doses followed by live attenuated or viral vector intranasal vaccine as a way to protect against severe disease but also reduce transmission, that is boost to prevent outbreak and variant cycle.
Yeah, if I may go first,
Please.
That is difficult, I have to say. So cellular immune response is difficult to assess and to assess in a reproducible manner. Antibodies, mucosal antibodies, are certainly not easier to assess. We have done this, I've done this in previous vaccine development programs as well, norovirus programs, for example, mucosal immunity being probably very important. But how a protective immune response can be assessed, or how mucosal IgA, for example, can be included in the correlation figures that have been generated. Jerome has showed them in his presentation, where Corey et al. And Christian Earl et al. Both correlated vaccine efficacy and neutralizing serum titers. How we can feed in the IgA and mucosal antibodies into this equation is very difficult. I'm afraid that with placebo-controlled vaccine efficacy trials being increasingly difficult in a more and more seropositive world, but in particular in a world where more and more vaccine is being rolled out, it is difficult to assess clinical efficacy or effectiveness for those types of vaccines and regimen. And I'm also not yet sure what a suitable immune correlate pathway, for example, towards licensure or towards public health decisions may be. But in theory, and yes, I completely agree, and there is a series of intranasal vaccines under development at the moment. This is a very interesting thought, and CEPI is also supporting some intranasal vaccines as well.
And just to add on a bit, so having done a correlates analysis that included a cellular component on 16,000 people, so 8,000 vaccine, 8,000 placebo recipients, I can tell you that the act of trying to standardize those cellular assays, and when you don't actually understand the correlate, antibody is one thing, and Plotkin says it's almost always antibody, and when it's not, it becomes much more difficult. And the act of drawing 10 cc's of blood at the peak post-dose immune response, so it's about 2 weeks or 4 weeks after the final dose, on 16,000 people, preserving those PBMC in a way, and now we're doing trials all over the world in a very standardized manner that will give you 90% viability of cells after shipping, is actually tremendously logistically complex. And to do the kinds of assays that the cellular immunologists want to do on 10 million cells is sometimes is difficult. So assuming 10 mLs of blood gives you about 10 million PBMC. So it would require that you have, as I would guess the Moderna group probably has set up a cellular working group, and that the group at the HVTN core labs and the CAVD at the gates are probably looking at the assays. And sometimes you have to do multiple sampling. So you have to design these composite T-cell complexes. And actually we showed that there was one that was associated with a lower risk of infection for HIV, but it did take quite a bit longer than the generation of a correlate of risk or potential correlate for the antibody response. And it does, and I'm not sure that all the studies have actually saved 10 mLs or 5 mLs of PBMC for the kinds of correlates analyses that are necessary to establish that.
That's a lot of immunology and a lot of acronyms, Jerome. I'm sure many of us understand.
I'm sorry.
Maybe not all. No worries. No worries. I mean,
actually, can I ask? Do you mind if I ask Jakob a question?
Please do.
Jakob, the live attenuateds. Can you use a live attenuated COVID vaccine as a challenge? So I mean, it's a vaccine, right? So it should theoretically protect. But on the other hand, could we use it like we were thinking about using rotavirus vaccine as a challenge for the non-replicating rotavirus vaccines? Can you use the vaccine itself? Or, for instance, I mean, inactivated polio vaccine with a oral polio virus challenge. Can we use that as a different way? And as you look very quickly at protection against infection or transmission.
I guess you could. Interesting question. I haven't thought about that, and I'm not a human challenge expert, but it takes a long time to establish human challenge models using wild virus, of course. Not just for safety reasons, really to establish and make sure that these types of challenge studies are actually doable and safe, but also to standardize them in a manner that data are acceptable by regulators. And I think your approach with, apart from them not being licensed either, I mean, anywhere, and certainly not in those countries doing these human challenge studies, they would be unlicensed products anyway. You would maybe be more on the safe side in terms of, you know, can we do this? Is this ethical and so on? But from a standardization procedure, I'm not entirely sure if you would gain a whole lot using those. But in principle, from an infection model, and to see whether or not antibody titers are being released, that might be an interesting, but one would have to use a different assay then, obviously, as the one that is included in the vaccine that is also being used in the challenge model. But that is, I guess, the same, irrespective of whether or not you use a live attenuated vaccine or a wild virus. Interesting thought. Okay.
Lots of interesting thoughts here, and Fiona reminds us that the live attenuated influenza vaccine was actually used in this very way on the human challenge, to look into it. But let me go back to Ron Duggan, who is still bringing up the indirect protection question to us. He's asking, can we ever think to control pandemic through vaccination without vaccinating young children heavily infected now with the Delta? But my understanding has been that the children don't actually play such a role in this pandemic as a reservoir for the virus. But am I completely mistaken? What is your, gentlemen, your view on the role?
Let me just clarify. We have data from Israel.
Yes, please, Ron.
The daily positives. We have thousands of daily positives per day, and anything between 40% to 60%, depends on the day, depends on the school opening, etc., are from children below the age of 12 that are not getting any vaccine. And we have now a big proportion of children under 5 and under 6 that are infected. So Delta in Israel is propagating easily in children, and there are so many isolations now of entire classes and entire schools because of that. And I'm not talking about 12 who could be vaccinated, often not. I'm talking about below the age of 12 and even below the age of 5. So at least in Israel, we know that the children vaccination is needed. That's where we live because of that. But we don't know, we still not have any license for that, and we don't know what will be the compliance. But definitely, they are playing an important role in the positivity rate today in Israel.
Ron, may I ask you whether this is actually the PCR positivity, or is this truly that you are doing isolation, that it's a live virus that can transmit? Because those are
no. It's PCR positivity.
Yeah. Okay.
But we do know that if you have a class where there is one positive, there will be often several positives, and other class there is no positive. So we did not do transmission studies as far as I know.
Yeah.
But we do have clusters, a lot of clusters in specific cities and specific schools. So it shouts out a high transmission, although I'm not aware of a study that brings you figures and exact figures in those children.
Yeah, I think that the pandemic has shifted. I think initially we saw a lot of cases in the old age group and we started vaccinating the older age groups. And then we saw a shift into the younger age populations. And this is also, at least in many countries that have initially implemented strict non-pharmaceutical interventions like face masks and lockdown and so on, children were at home, so they had no chance to get infected. Now with countries opening up again, children going back to school, I think there was a shift, not an epidemiological.
Well, but that was not the case in Israel, where children were not wearing masks anyhow and extended family.
Yeah.
It is from going from beta to delta, from alpha to delta variant. The delta variant is completely different in terms of children compared to the beta. We achieved complete 0 cases in children once we vaccinated the young adults and the older adults. So we were believing that there is a fantastic herd protection. And this changed in one day when Delta came in.
That's exactly, thanks, Ron. That's exactly the point I was going to make. I hear everywhere that you need to vaccinate 70, 80% of your population to reach a herd immunity threshold. Now, herd immunity in general relies on sterile immunity. Then you can calculate the exact threshold that you need for protection based on R0, of course. And with an imperfect protection against infection with this vaccine, and in particular with a even less imperfect protection against variant infections, I don't really know where this herd immunity threshold may be, and I would be curious to hear others' opinion on this. However, I think vaccinating children, again, is probably primarily useful from an epidemiologic point of view, kind of a transmission pandemic point of view, rather than disease. But you have probably seen that companies are already very active in developing pediatric formulations. Pfizer, BioNTech have released a press release, I haven't seen data yet, on the dosing of 5 through 11-year-old, and they claim that the immune response was non-inferior. But by the way, that's a 10 microgram formulation, and the immune response in 5 to 11-year-old was non-inferior to the immune response in 12 through 25-year-olds that had received the normal 30 microgram dose. And Pfizer is even developing an infant formulation with 3 micrograms that is currently being tested in that same trial, 6 months through 4 years of age, but no data released yet. So vaccines are under development for pediatric and even infant populations, but we'll have to see. They seem to be very immunogenic.
My last remark to what you said, Jakob, when you talk about 70, 80% of the population, it may be correct when you talk about the population, but if you divide the population into adult or older population, when you get 70%, and a younger population, when you get 0%, it depends on the circulation. In pneumococcus, you can vaccinate 100% of the adults. You'll not get herd protection because if you don't vaccinate the children, vice versa. Exactly. Hepatitis A is only the children, you don't need to vaccinate adults. So in this case, you have a population that now becomes very infective that doesn't get anything. And so the UK is not vaccinating children. This is why I was asking the question, because we have 2 approaches now, or 2 potential approaches.
Yeah, and I'm so just as the brother of a person who runs a school, and the things that they're going through in order to try and prevent infections in children who are not vaccinated. And to prevent transmission to family members. And it's a very complex question, but we know that the Delta variant, certainly, and even the earlier variants were as transmissible, if not more transmissible than influenza. And we have the data that vaccinating children actually protects adults from Japan. And at that time, we weren't necessarily thinking about doing it because the goal was to protect the populations that would die if they got infected, rather than to protect them secondarily. But I think as we start to think about this, we know that the presence of heterogeneity in a population for vaccination or immunity creates outbreaks. And the initial data that children may be more resistant based on seasonal coronaviruses, I think that was interesting, and maybe they were partially protected, but not. I think Delta is different, and we're really going to need to think about this as something where heterogeneity in vaccination rates, whether it is in different communities or in different age groups, is going to be a problem. And I think Ron hit the nail on the head.
So Jerome, if you then had to decide now for Korea, whether you go for boosters for the elderly and immune compromised versus whether you go downward vaccinating children, what would your advice be for your government?
So I think that the Korean government would base it primarily on the greatest risk. So they track ICU admissions and hospitalizations and where people are dying. And so the beauty of Korea is I can give you examples from these schools that are after school of the outbreaks in those schools. And a class of 10 students, 8 of them get infected, and then they transmit. We have all the secondary and tertiary spread patterns for all these students because they have lots of friends and they get around and they infect lots of people. So I think it's they will do it based on risk, and the people and populations at the greatest risk. They know that the children and they do isolate schools that have outbreaks. So they are doing that as well. But this is a part of, kids are still wearing masks in school. Although I have to say, I did walk down the street the other day and I saw a bunch of them playing a video game, masks off, all clustered, all the heads together around a single video set. So it's a difficult group to work with. But in school, they do, I actually told in the preschool, they enforce masks, which is really amazing. I don't know how they would get a 4-year-old to wear a mask. But so I think that they'll look at the risk and where the populations are at greatest risk, especially since they still haven't vaccinated all the people they want to have vaccinated in the in the group before the children. So.
Okay, we're coming close to the end, and I would like to take 2 more questions to you. I mean, there is from Nicholas Payrod, was asking on your views on the RNA technology and some of the other technological platforms and how you view them for the future. This certainly will be a topic for another ADVAC alumni webinar separately, but I mean, just to hear your quick thoughts, Jakob and Jerome, on what do you think that the future will provide us from these platforms that now have proven very, very successful?
Shall I go first?
Yeah, please go first, Jakob.
So I have to say I was kind of falling off the chair when I saw the first vaccine efficacy result last year. I think that was fascinating. I also think there's a lot of future, advantages in this platform technology when it comes to rapidly adapting vaccines to new outbreak strains. And CEPI is looking into this very much. We are currently preparing our strategy for CEPI 2.0. We have ambitious goal formulated, including a 100-day moonshot goal. So based on mRNA, vaccines had generated vaccine efficacy data in 309 and 315 days, I think. Pfizer and BioNTech both were licensed or at least emergency authorized in the US in less than 365 days. There might be ways, at least from a technical point of view, regulatory point of view, we'll have to see, to adapt those vaccines even quicker to newly emerging pathogens. I wouldn't be surprised if 10 years from now, the majority of influenza vaccines might be based on the mRNA technology, simply because you can adapt them easily to seasonally circulating strains. But this is, I'm completely speculating here. But I don't think the mRNA technology is the answer to everything in vaccinology. We'll have to understand them much better. We have to understand reactogenicity safety events a little bit better. Everything seems to look okay. I mean, we have vaccinated millions of persons, and yes, we have seen signals, but I think we are in it is a good benefit risk profile that we have seen. But we also have other viruses. We in CEPI, we're looking into Lassa, for example, and it looks like the pathway to immune protection in Lassa disease is based on the cellular immune branch. And we don't know if it's really a disease. Yes, I agree. Stanley Plotkin keeps saying usually it's the antibodies, but there are some diseases, for example, the herpes zoster vaccines are also based on the cellular immune response, and we'll have to see how good mRNA vaccine technology will be in these, across different pathogens and pathophysiologies. But very promising, exciting technology.
Thanks a lot, Jakob. And how about you, Jerome? How do you view these different platforms?
So I agree with Jakob that there are going to be platforms, primarily viral, I would guess, for which these RNA vaccines will be very interesting and useful. And I'm thinking about things that are very genetically diverse, like noroviruses, or hepatitis C, or maybe even HIV. I don't know how they'll fare as much for things where we're using conjugate vaccines that stimulate primarily Th17 responses, and will they do the same thing? Will sufficient levels of antibody be enough? Or is there some component of T cell help, the Th17s or others that may be important? I don't know. And would you really reinvent a vaccine just so that you can make RNA, make them all in RNA vaccines? And maybe you would do that. The other part of this is, and I think as RNA vaccine technology improves, maybe we'll be able to deliver antibodies with RNA. So get the RNA vaccines to be long-lasting, or things that will generate long-lasting protection through antibody. But again, I think that's in the future, although I know people are working on it now. I think adjuvants are another thing that we've learned a lot about during the pandemic, and our appetite for risk regarding adjuvants has really, changed. I mean, that the Bharat vaccine has been given to, I forget, 50 or 60 million people now with this immunoquinolone adjuvant. And again, that's a huge safety database. And so there are certain things I think that have improved. And then we have the protein vaccines, which, as predicted, did take a bit longer, maybe Novavax being the exception, although production has been, I guess, a question. And they may be important as we look at other populations where people aren't as comfortable using RNA vaccines. Or I think Dr. Fauci even said he's waiting for Novavax. But again, I think that there could be some of these platforms that have proved very useful, and that should be applied to some of the big additional questions that we have ahead of us in vaccinology. So can I make one other thing? And this actually gets to one of the points. And I think the other thing that we need to think about is how we're going to do the testing in the future. Because, Korea still does testing and tracing and a huge number of tests every day. 2% or so are positive, even with 3,000 infections. So they're doing testing and tracing and looking up contacts. But as we increasingly vaccinate the population, and maybe that includes the children as well, when is this going to be something that we do primarily for people who are sick? And then, look at the other things around the people that are, potentially exposed to them. I mean, when do we start to change the way we think about how we diagnose and what we consider to be clinically relevant infection? I think at the same time as doing that, we have to remember that we have to have some form of surveillance in place, because at some point there will be mutants, and we want to be able to pick those up quickly and make sure that we have vaccine coverage against them. Anyway, thanks.
And if I'm sorry, Hanna, but I think we should mention the question of mRNA, not to forget about the very challenging storing conditions at the moment. And mRNA is not mRNA. Some have not advanced into the clinic so far, still challenges. Others have shown or remained below the expectations, CureVac, for example. So it's not that straightforward, but again, fascinating technology.
Yeah, thanks, Jerome, for raising that up. I mean, it's not necessarily vaccinology that you're talking about, but certainly it's something that all of us in the national programs need to think about on what is the testing and tracing. And we've been conditioned into it and looking into infections. And now we should more gear towards looking what are the measures of the success of our programs. And that may be a topic of another webinar, just like the childhood vaccinations will be, and the different vaccine technological platforms will be another topic for these ADVAC webinars, which I at least find very, very useful. There was a very last comment or question from Nicholas Payrood, who was asking on what more data does and evidence does WHO need in order to make its recommendations on the booster doses, and this is exactly what we are struggling with on daily basis with Joachim Hombach and Annelies Wilder-Smith and Shalini Desai and others, Sonali Kochar on this call as well. And please tune into on October 5, there will be a SAGE meeting discussing the COVID vaccines and boosters to a certain extent. And then especially for the inactivated vaccines, the Sinovac and Sinopharm. And then we are planning on a complete booster session, extra SAGE session on November 11th. So those are open to public and also to the ADVACers. So please tune into those, and let's see that we get to the kind of recommendations that will be helpful for the NITAGs and RITAGs working in countries. So I want to thank warmly our speakers, Jakob, Cramer, and Jerome Kim, for making yourself available and sharing your wisdom. And thank you for all the ADVACers for your thoughts and lessons learned, which I can see in the chat. This session was recorded, so you can watch it afterwards, and stay tuned to the next webinar. So take good care of yourself and stay well. Bye-bye for now.
Bye. Thanks, Hanna.
Thanks, Hanna. Thanks, Jerome.
Thanks
Thanks, everyone.
Thank you, Jacob.